Good afternoon, everyone. Our topic is hope when it appears hopeless. Surgery in severe traumatic brain injury patients with fixed dilated pupils. Now, it is in the code of neurosurgery that when the dynamics force us to evolve constantly, we are supposed to see every patient and we get to learn from every patient. And every patient has an outcome which eventually teaches us whether we are going on the right path or not. So in our traditional teaching, we have had patients who presented with a score of GCS, that is Glasgow Coma scale of 3. So this scale basically is a tool for analyzing the consciousness of the patients, with 3 being the lowest, 15 being the highest. So we are up to 15. So patients who have a score of 3, they have E1, that is eye is not there, VT, that is patient is intubated, is not at all speaking, and one patient which is basically there is no response to any motor stimulus. So such patients, when they present, naturally we tend to think that these patients are either deep in coma or they are brain dead. And we have additions to that, that patient has fixed dilated pupils. That means even the brainstem has had some sort of impact. So in our teaching, we have had that such patients have poor prognosis, and it is better because the dynamics in neurosurgery and trauma are very fast. So we have to choose which patient is salvageable, which is not. So in our setting, which we have resource limitations, so we prefer to give patients like M2 or M3 that will give them a chance. And normally these patients we observe and declare them because eventually they have a very poor prognosis. But in we have over time we have seen that this might not be true in every case. So let me take you along into our journey of this. So, in our traditional teachings, we have two papers. I'll just give a brief overview. These two papers were conducted between 2001 and 2003 and 2005. So, they gave an insight that patients who are M1 and who are still alive, they have a almost 100% mortality when it comes to dilated fixed pupils. So, it was assumed and it was concluded that makes certain sense. In fact, one of the Indian authors has straight away said that need to consider stopping treatment and discussing if patients in surgery may not be warranted. So this has been traditionally that why to waste resources. But the question comes, what if such patients are operated? What if they are operated on time? And what if the outcome is different? So these there are cases which force us to honor upon such situations. So we have two cases which I'm going to discuss. One is a 43-year-old female. She presented with history of falling down level after sleeping on 28th of March, 12:40 p.m. Patient had loss of consciousness and episode of vomiting. She was taken initially to Hamdard Institute of Medical Sciences. Patient was not intubated. She was just given some first aid and referred to trauma center. The patient, when they came to trauma center, we saw there was a liver compromise. It was intubated, and the patient had a very high BP. She was not hypertensive, but the important thing was the disease was M1, and people were fixed and dilated. So in this setting, the first thought that came was probably patient is brain dead. So what to do? The past history was of being a hypertensive and investigations were fairly normal. And when the CT was done, it showed the right side cerebral bleed and an extension throughout the ventricle. So in this patient, immediately the right frontal, the ventricular dilation was done. EVD was put and the patient was taken up for posterior fossa decompression. The posterior fossa was decompressed, C1 arch was removed, and the brain was intraoperatively very tense, cerebellum. So the evacuation of the bleed was done. After evacuation, when we took out the bleed, the cerebellum was lax. We did a lax plastic. We took a facial after we repaired it loosely so that there is no there is a very loose cut. So if it expands, so there is no obstruction. So this was after that the patient had his CT. We can see a fairly good decompression. We can see the blood happening almost evacuated to the posterior fossa, but the bleed is still there in the ventricle. But the ventricle has now relatively reduced in size due to the EVD. So post-operatively, miraculously, we saw the patient on post-operative day 0, patient improved. This was surprising, and the pupils came back to normal reactivity. Even he had 100 ml of CSF mixed with blood. On second post-operative day, the patient came to M6 drowsy state, and patient's BP was well controlled with antihypertensive. So we just instructed them to so this was an eye-opener that the patient had recovered despite the dismal prognosis that we assumed. We had another case of a 53-year-old male patient in October 2023. The patient again had injury RTA and patient was referred to process. There was also consciousness with exposure vomiting and green was present. Now, in this case, when the patient arrived, the patient was unfit and the patient was intubated in view of threatened airway. And in this case, you can see there was a right frontal bone fracture. So here we can see there is still some amount of basal systems are visible. There is a left temporal contusion, there is a right basic frontal contusion. We can see, and we have planned to share this patient to ICU. So under sedation, when we shifted, we found that the patient had dipped there in ICU itself to disease of M1. So immediately we got a CT done again, and when we got a CT done again, this time we can see that the systems are relatively effaced. We can't see the systems, and because the patient was in we didn't waste time. We shifted the patient immediately to the OT, and we did a decompression of this patient. So this was a decompression that was done. Post-operatively on POV 0, the patient had come back to M4, and on post-operative day 2, patient came back to M5. But the stigmography was done because of the M5 status, and we didn't see the patient was not very much right to the tube. But on fifth day, the patient came to M6 drowsy state, and we were able to wean off the patient to CPAP. By POV 10, patient was on room. And again, this was something out of the box outcome. So the patient was eventually discharged. This gets back to the literature review. Basically, gives us a change. I would like to request to shed light on this.
Good afternoon, respected faculties, my dear colleagues, and residents. So, frankly speaking, both these cases, I was also in dilemma whether to leave the patient as such to their destiny or to operate them. I even asked my residents what is their view. So, most of them say, since the prognosis is poor, we shouldn't operate these cases. Anyway, they will be in a vegetative state, and their life would be not useful for themselves as well as for the relatives. So I discussed this thing with my seniors, Professor Dr. Deepak Agrawal sir, and he says, let's give them a chance. So we give them a chance, and both of them improved. So we reviewed our literature. The literature says about this kind of patients. The patients presented in E1 VT M1 status, and the pupils are dilated fixed.
Can I quickly ask a question? What was the long-term outcome?
The first patient, that lady, is still in the ICU. She is improved to M6. She is hypertensive. She is on antihypertensive medicines, and she is doing well. The other patient was the father of a medical student. He was from MMC. So he is still under follow-up. He is still intubated, tracheostomized, and he is still M6, and he is waiting for cranioplasty. So, like Dr. Akshay highlighted that earlier there were only case reports about the outcome of such patients. So, first series that was published in 2003, which included 10 patients who had a GCS of 3 and they have fixed dilated pupil. They said the mortality was 100%. However, in their series, there were 33 patients who have a reactive pupil and GCS of 3. The mortality was 67%. So they say it's better not to operate such patients. Again, this is a Canadian study group, and they published the study in the same journal, and they included 173 patients, and they also included patients with GCS3 and with fixed dilated pupils. They also included patients who are intoxicated or received any pre-hospital paralysis, and still the mortality rate was 100%. So they are on the favor not to operate such patients. So this study was by an Australian group, and they are deadly against wasting useful resources for such patients. However, as you can see, there were some patients who have a pre-hospital GCS of 3. And the patient who remain, who are admitted at the hospital and the GCS remained 3, the mortality rate was 100%. Only those patients who have transiently shows an improvement more than 3 survived. So out of that 93 patients, only 6 patients survived. So they are of the opinion stop treatments of such patients and discussing for organ donation. And they analyze the resources utilized in patients who remain GCS3 with fixed dilated pupil. How many ICU hours has been wasted? How many ventilator costs has been wasted? So this is an important paper which was published in 2009. So it is published in European Journal of Emergency Medicine. So it is a multi-centric study. So they analyze the data from the International Traumatic Coma database. They show some patients. The patient with the GCS of 3 and fixed pupil dilated pupil in the field probably have a mortality of 90 to 95% and 2 to 3% chance of good functional recovery. So out of 74 patients who have bilateral fixed dilated pupil, 3 have a good outcome. So the best part of this, they assess the GCS at the time of in the field. That is when the patient was first seen by the paramedics, not at the time of admission to the hospital. So at that time, if the GCS was 3 and the patient has a bilateral fixed pupil, almost 3 patients has a good outcome. But they did not analyze what were the factors responsible for it. So this is a literature. This is a very good study published in Journal of Neurosurgery in 2009. So they included 189 patients who have a GCS of 3, and they mainly stress on the pupil size and reactivity. So those who have bilaterally fixed dilated pupil, the mortality rate was 80%. However, 10 patients who have a bilateral fixed dilated pupil are able to achieve a GOS score of 3 or 4, that they have a good functional recovery. So in 2014, Spotter published a systematic review and meta-analysis in the patients who are undergoing surgery for the traumatic EDH or SDH. So the factors influencing the outcome, the most important was the pathology. If the patient has an EDH, it has the best outcome. Almost two-thirds of the patients survived and majority have a good functional outcome. In SDH, however, the outcome was not good, but 33% survived and 6.6% have a good functional outcome. And the second important factor is the age of the patient. If the patient is younger age, so the chances of survival are more and functional outcome is good. And the third important factor is the delay in the surgical intervention. So if the surgical intervention is delayed more than 6 hours, the outcome is very fatal. So they said that they found no survivors in patients who were GCS3 and surgery greater than 6 hours after people became fixed and were older than 65 years. So similar study, that systematic review and pool analysis done in 2012. So they are of the conclusion that neurosurgeons or the treating surgeon should not be God. So they should analyze each and every patient individually. So in a setting of stroke or trauma, the clinical finding of bilateral fixed dilated people should not be relied as an evidence of death, and patients should not be deprived of life-saving decompensative surgery in this setting. So they have a favorable outcome of 17%. They analyzed around 563 patients. So after the literature review, I call my senior Dr. Deepak Agarwal sir, Professor DSL, for the concluding remarks.
Thank you, Rajesh. What I would like to highlight extra here is, see, in any system, all these patients are coming in the middle of the night. So it's that all decision making is happening around midnight or after midnight, and everybody is interested in not doing it. That is the way. And it's a resident run system everywhere in the world. So residents have already seen the poor outcome in these patients M1, M2. Even M2 patients have a very poor outcome. So most faculty here and anywhere in the world would not touch these patients. They would say, okay, just shift them in the ICU, prognosticate them. My my thinking is that if we have to make this system efficient, we have to make the workflow efficient because the residents are changing, faculty are changing. So they need to be firstly ready to operate in the middle of the night. Everybody should be ready. The second thing is that all of us need to see even those 1%, 2% patients who actually improve and go back home to a very good outcome. Although we might be creating a pyramid with a lot of vegetative patients or patients who finally die, 90% will die anyway. But unless we create the system, we will never be able to save that one patient who comes later. So that is the crux of our working towards trying our best. Our system is different from those seen in the US and anywhere else. We should not copy because for them, expense is the main thing. You know, they are seeing that ICU hours, it's costing them millions of dollars to maintain a vegetative patient. It's not so in our place. And if we at AIIMS cannot do it, then where can it be done? So having all these things at the background, uh, at least I am very aggressive with these patients. It cannot be, would say, translated to other people. And we have seen, I think, all the take home message here is every resident who goes out of our department knows that there is a chance. That is the most important thing. And he or she has seen patients actually go back home in their career, maybe once or twice, or maybe more. And so, this is what I think everybody needs to understand.
Yeah, I think it's and as you said, even within my yes, we just each of these never going to come to operate with somebody good. I suggest that as we keep doing this kind of approaches, we correct our data carefully so that we are able to come up with say the chances of success in patient higher if we have these criteria. Just to have a clear approach, one way or the other. If they are not going to operate in one, or we operate everyone who comes to us, all of them may have some drawbacks. So we need to have information and evidence inform our decision. Of course, it always some huge part of medical and surgical decision making is driven by the personality of the person. And we tend not to talk about that of course is as you are presenting this, I think we have patients with malignant melanoma, multiple metastases, and the idealized was we look after not spend so much money on oncologic therapy that will make you sell your home and your land and the children will then be. But we have one patient necessarily on this. So it comes back to the same question: how do you identify those and justify the system being built on this rare? That's one aspect. The other you related is that one outcome is survival. So what are you thinking of in about 6 months, 1 year, 5 years down the line?
these patients will survive, what is the family quality of life.
Excellent, excellent question. See, for the first, there is no clear guidelines anywhere in the book. And what else? And because most of the patients who have AIIMS are the elderly. So it is very rare to get a very senior person having AIIMS. Most of them are young patients who have that. The treatment itself becomes. Number two is that there is so much bias in the system. For every every individual sometimes his experience and personality and everything. So people are already biased in their and it does not. So I would say because of extreme bias, the results are not good. There is no official result because 80% of the bacteria are not affected. They are anyway. So it's very difficult to get any meaningful result. For the second question is that are we creating a pool of dedicated my take is that a system that has good many works for the poorest outcome. So if we want a good outcome for the best, we have to make sure that the same way is done. And this is a very, I think it's a very interesting issue because across the road we have living. And we see that for the for the patient itself is not. And the reason is the attitude, nothing else. So because everything is there, once that attitude sets in, okay, in the middle of the night, okay, he's fine, whatever, it doesn't make a difference. Then you stop operating, or you stop taking decisions which are in the interest. So it's a difficult thing to do, and it's very difficult to put in practice because it's all there. We are in the reality possible. And that's why it's important that we continue to be extremely aggressive all the time. This, I think, is not a changing right.
Thank you.
I mean, I'm not really that much. So, as far as my understanding, the nice presentation, but as far as my understanding, is one felt to be like it was an hypertensive day. So, in a strict sense, can't be called that traumatic brain. Second case was one presentation had a good disease that became worse. So, I think those factors actually might have helped them in that the good outcome that they might have had. I just want to ask because those patients who come with TCF3 or presentation, do we have any outcome on those kinds of patients with diabetes?
See that both are relevant, but we do not, I would say, differentiate between hypertension may actually. The question is if we dilated pupils, is the patient brain-dead? That is the question that is there spontaneous respiration? Is there compulsory gag? So if spontaneous respiration is not there, then there is no question of it. Now the patient is having spontaneous respiration. Now it's the second question I ask is how long is this thing? That is the important. If we redirect within days, within I would definitely think for those. Because they have these things patients anxiety. I don't get the so many because of the addiction, patient is better and become. And then say because patients are already in front of you take the OT and do the and patient becomes. This you all know mistake. Yet you not replicate the patient. Patient coming from outside, you don't know this time. We are not. We should only know that this patient is a good. What happens
I think we can, although most of I also thought of attending with this because I thought it was very fascinating. We also asked emergency to see. So I just wanted to know what it's and that's it's a nice decision. I just want.